Start with chapter 41 of your Apurba Sastry Essentials of Microbiology, which is gastrointestinal infection due to Enterobacteriace. In this chapter, we will be reviewing family characters, Escherichia coli infection, Shigellosis, non-typhoidal salmonella, and the non-GI pathogens. So, the family characters and E. coli infections will be dealt with in this video, while Shigella, non-typhoidal salmonella, and non-GI pathogens they will be covered in the subsequent videos. Now, the family Enterobacteriaceae includes the commensal bacteria in the human intestine called coliform bacilli, includes such as Escherichia, Klebsiella, Enterobacter, Proteus, Morganella, Providencia, and Citrobacter, etc., and also includes some enteric pathogens such as Shigella and Salmonella. Family characters, general properties. Members of family Enterobacteriaceae should have the following properties. They are gram-negative bacilli, aerobes and facultative anaerobes. Non-fastidious, can grow in vessel media like nutrient agar, ferment glucose to produce acid with or without gas, reduce nitrate to nitrite. They produce catalase except Shigella dysentery type 1. They do not produce oxidase. They are generally motile with peritrichous flagella except for some members which are non-motile such as Shigella and Klebsiella. Classification. The oldest method of classification of the family Enterobacteriaceae was based on the fermentation of lactose on McConkey agar. It is still the most widely used classification, has great practical application and laboratories to differentiate various members. Ewing's classification. Though several classification schemes were proposed for Enterobacteriaceae, the Ewing's classification was the most popular. It classifies the family Enterobacteriaceae into 8 tribes. Each tribe further comprises of several genera. Use of tribe has great impact on the laboratory for easy identification as genera under each tribe share common properties. New method of classification. After the availability of molecular methods, the taxonomy is further changed. In 2016, the older Enterobacteriales was given the priority. Order Enterobacteriales was given the priority and several new families within the Enterobacteriales were proposed, consisting of species that were formerly members of family Enterobacteriaceae. However, Ewing's classification is still commonly followed. The members of Enterobacteriaceae that are gastrointestinal GI pathogens are discussed below. The members which mainly cause non-GI manifestation are discussed in the respective systems which they principally infect. Escherichia coli infections, we'll see. It was described by Escherichia in 1885. E. coli is the most important species encountered as human pathogen. Table 14.1 shows the classification of family Enterobacteriaceae based on lactose fermentation. Groups. Lactose fermenters. Colonies on McConkey agar ferment lactose and produce pink colonies. Examples are Escherichia and Klebsiella. Non-lactose fermenters do not ferment lactose, produce pale or colorless colonies. Examples are Salmonella, Shigella, Proteus, and Yersinia. Late lactose fermenters, LLFs, ferment lactose late, produce pink colonies only after 2 days of incubation. Examples are Shigella soni. Ewing's classification of family Enterobacteriaceae, type 1 Escherichia, genus Escherichia and Shigella, type 2 Evardsillae, genus Evardsilia, type 3 Salmonellae, genus Salmonella, type 4 Citrobacteriaceae, genus Citrobacter, type 5 Klebsiella, genus Klebsiella, Enterobacter, Hafnia, Serratia, Pantodia. Type 6 Protei, genus Proteus, Morganella, Providencia. Type 7 Yersinia, genus Yersinia. Type 8 Erwinae, genus Erwinia. Now, E. coli is the most common aerobe to be harbored in the gut of humans and animals. After excreted in feces, it remains viable only for some days in the environment. Hence, the detection of E. coli, especially a variant called thermotolerant E. coli, survives at 44 degrees Celsius, is taken as an indicator of recent contamination of drinking water with human or animal feces. The other species are less important as human pathogens. These include Escherichia fragiosoni, Escherichia harmani, and Escherichia vulneris, which are rarely isolated from clinical specimen. Virulence factors of E. coli. Virulence factors of E. coli may be grouped into surface antigens and toxins. Surface antigens. E. coli possess 4 surface antigens: somatic O, flagellar H, capsule antigen K, and fimbrial antigen. Serotyping of E. coli is based on agglutination with the specific antisera directed against each surface antigen. So far, more than 174 O serotypes, 100 K serotypes, and 53 H serotypes of E. coli have been recognized. The strain of E. coli is designated based on the number of its antigens. For example, O121 K37H8. Somatic or O antigen, it is a side chain present on the lipopolysaccharide antigen. It is a major surface antigen, induces antibody formation. Flagellar or H antigen, H from Hodge, meaning film of breath. It is responsible for bacterial motility and therefore contributes to their virulence. Capsular or K antigen, K for capsule, German for capsule. It is the polysaccharide capsular antigen present on the envelope or microcapsule. When present, it encloses O antigen and renders the strain inagglutinable by O antecedent. It may contribute to virulence by inhibiting phagocytosis. It is expressed only by few strains of E. coli, example those causing neonatal meningitis, pyelonephritis, and septicemia. Fimbrial antigen, pilus, is the organ of adhesion, helps in attachment and colonization. Various fimbrial antigens are CFA, colonization factor antigen. It's a type of fimbri expressed by enterotoxigenic E. coli. Mano-resistant fimbri, these are expressed by uropathogenic E. coli and help in colonization of these strains onto uroepithelial cells. P. fimbri binds specifically to the P blood group antigen present on the human RBC and uroepithelial cells. Toxins. The exotoxins secreted by E. coli are of several types. Enterotoxin, they are produced by diarrhegenic strains of E. coli. They are of three types: heat labile toxin, heat stable toxin, and virocytotoxin. All have been described in detail. Cytotoxic necrotizing factor CNF1 and secreted autotransporter toxin SAT. They are cytotoxic to bladder and kidney cells, act as virulence factor for pathogenesis of UTI. Clinical manifestations. E. coli is one of the most common pathogens encountered clinically and has been associated with various manifestations. Urinary tract infections, UTIs. It is caused by uropathogenic E. coli, UPEC. It accounts for 70 to 75% of all cases of UTI. Diarrhea, it is caused by 6 pathotypes of diarrheogenic E. coli: enteropathogenic E. coli, EPEC, and enterotoxigenic E. coli, ETEC. Now, let us see the various properties of enterotoxins of E. coli. LT, heat labile toxin, produced by enterotoxigenic E. coli. It resembles cholera toxin in its structure and function, but is less potent than the latter. Mechanism of action has two peptide fragments, A and B. Fragment B is the binding fragment, binds to GM1 ganglioside receptors present on the intestinal epithelium, following which A fragment is internalized. Fragment A is the active fragment, causes ADP ribosylation of G protein, activates adenylate cyclase, results in the intracellular accumulation of cyclic AMP, leads to increased outflow of water and electrolytes into the gut lumen with consequent diarrhea. Plasmid coded, and the detection of LT, toxin detection by latex agglutination or ELISA, and molecular methods are PCR detecting gene coding for LT. Next come the ST, or the heat stable toxin. Produced by enterotoxigenic E. coli, mechanism of action: it binds to the guanylate cyclase C, increase the production of cyclic GMP, fluid accumulation in gut lumen, and causes diarrhea. Again, it's plasmid coded and detection is same as for LT. Now last, the virocytotoxin or Shigia toxin, produced by enterohemorrhagic E. coli, is so named because it is cytotoxic to viro cell lines. Mechanism of action has two fragments, A and B. Fragment B binds to globotyrosyl ceramide GB3 receptor on intestinal epithelium. Fragment A is the active fragment. It inhibits protein synthesis by inhibiting 60S ribosomal subunit. Bacteriophage coded. Detection of VT, serologically latex agglutination, ELISA, molecular methods using specific DNA probe, cytotoxicity on viro and HeLa cell lines. Okay. Now continuing the clinical manifestations. Others are enteroinvasive E. coli, EIEC, enterohemorrhagic E. coli, EHEC, enteroaggregator E. coli, EAEC, and diffusely adherent E. coli, DAEC. Other infections, abdominal infections. E. coli is the most common cause of both primarily bacterial peritonitis occurs spontaneously and secondary bacterial peritonitis occurs secondary to the intestinal perforation leading to spillage of common cell E. coli from the intestine. It also causes visceral abscess such as hepatic abscess, pneumonia, especially in hospitalized patients, ventilator-associated pneumonia, meningitis, especially neonatal meningitis, wound and soft tissue infections such as cellulitis and infection of ulcers and wounds, especially in patients with diabetic foot, bacterial prostatitis, most common cause, osteomyelitis, and endovascular infection and bacteremia. Now comes the lab diagnosis. E. coli infections. Sample collection depends on the site of infection, urine, stool, pus, wound swab, blood, CSF, etc. Direct smear gram-negative bacilli and pus cells. Culture blood agar, grey, moist colonies, McConkey agar, flat pink LF colonies. Culture smear and motility, motile gram-negative bacilli, identification catalase positive and oxidase negative. ICUT test, indole positive, citrate negative, urease negative, TSI gas positive and H2S negative. Automated systems such as Marletov or Vitek, antimicrobial susceptibility testing. Now comes the laboratory diagnosis of UTI has been described in the chapter. The diagnostic methods specific for diarrhegenic E. coli has been described under diarrhegenic E. coli later in this chapter. Sample collection depends on the site of infection, like the sample collection E. coli disease. Specimen collected, pus, exudate and wound swab in the cellulitis or wound infection. Midstream urine and urinary tract infection. Stool and diarrhea, CSF and meningitis, peritoneal exudate and peritonitis, sputum and pneumonia, tracheal aspirate and ventilator associated pneumonia, and blood and bacteremia. Direct smear of specimen by gram staining. E. coli is gram negative, straight throat, arranged singly. Plenty of pus cells are also found in direct smear. Culture. E. coli is an aerobe and facultative anaerobe. It grows on ordinary culture media at an optimum temperature of 37 degrees Celsius in 18 to 24 hours. The culture media are as follows. Blood agar and McConkey agar. Blood agar colonies are grey, moist and occasionally beta hemolytic, mainly UPEC strains. McConkey agar produces moist, flat and pink colonies due to lactose fermentation. Like you can see in the figure, the moist pink pink colored colonies. Okay. Now the culture smear and motility testing. Culture smear of the colony shows gram negative bacilli arranged singly. Hanging drop reveals motile bacilli by peritrichate flagella. In this figure, you can see the gram negative bacilli. Okay. Now, identification. Identification of E. coli from colonies is made either by automated identification systems such as Marletov or Vitek or by conventional biochemical tests as described below. E. coli is catalase positive and oxidase negative, ICUT test, indole test positive, citrate test negative, urease test negative, and TSI triple sugar iron agar test shows acid upon acid. Gas present, H2S absent. Antimicrobial susceptibility testing, it is necessary to administer appropriate antibiotics. It is performed either by disk diffusion method on the Muller-Hinton agar or by automated MIC based method, example Vitek. E. coli can rapidly develop resistance to the multiple drugs. Many strains of E. coli are producers of beta lactamases such as ESDL, extended spectrum beta lactamases, AMP-C beta lactamases, and MBL metallo-beta lactamases. Now the treatment of E. coli infections. Treatment is essentially based upon antimicrobial susceptibility test report. Majority of E. coli required in hospitals are multi-drug resistant MDRs, resistant to more than 3 classes of antimicrobials such as aminosilins, third generation cephalosporins, quinolones, cotrimoxazole, etc. However, if found susceptible, then these agents may be preferred. Carbapenems, amikacin or beta-lactamase inhibitor combinations such as piperacillin, tazobactam or ceftriaxone and sublactam are usually the agent of choice for hospital-acquired MDR E. coli infections. Polymyxin, fosfomycin and tigecycline are the next-line antimicrobials for carbapenem-resistant isolate. Example, carbapenemase producing isolate. In India, prevalence of carbapenem-resistant E. coli is reported to be around 11 to 27%. In healthcare facilities with high prevalence MDR E. coli, empirical treatment should be started with high spectrum antimicrobials such as carbapenem. The therapy can be tailored based on the susceptibility report. Now, diarrheagenic E. coli. Diarrheagenic E. coli are antigenically distinct from the commensal E. coli, which colonize the intestine. Only a few serotypes of E. coli, which express the enterotoxin or other virulence mechanism, can cause diarrhea. The WHO estimated that more than 300 million illnesses and nearly 20,000 to 2 lakh deaths are caused by diarrheagenic E. coli globally each year. There are 6 pathotypes of diarrheagenic E. coli as described below. Enteropathogenic E. coli EPEC. EPEC frequently causes infantile diarrhea outbreaks and occasionally cause sporadic diarrhea in adults. Person to person spread is seen. It is non-toxigenic and non-invasive. Mechanism of diarrhea includes adhesion to the intestinal mucosa mediated by plasmid coated bundle forming villi which form cup-like projections called pedestals. AE lesions, attaching and effacing lesions. These are typical lesions produced on the intestinal epithelium which lead to the disruption of brush border epithelium causing increased secretion and watery diarrhea. Enterotoxigenic E. coli ETEC is the most common cause of traveler's diarrhea, causing 25 to 75% of the cases. It causes acute watery diarrhea in infants and adults. It is toxigenic but not invasive. Pathogenesis of ETEC by attachment to the intestinal mucosa is mediated by a fimbrial protein called CFA, colonization factor antigen. Toxin production, the heat labile toxin acts by increased cyclic AMP. Heat table toxin increased by cyclic GMP. Diagnosis, detection of the toxin is the mainstay of diagnosis. Enteroinvasive E. coli EIEC is the biochemically, genetically and pathogenically closely related to Shigella. Pathogenesis EIEC is non-toxigenic but invasive. Thus, epithelial cell invasion is mediated by a plasmid-coated antigen called virulence marker antigen VMA. Manifestations. These include ulceration of bowel, dysentery, diarrhea with mucus and blood called bacillary dysentery resembling shigellosis. Diagnosis, detection of VMA by ELISA HeLa cell invasion assay. Compared with other E. coli strains, EIEC are biochemically atypical, being non-motile and lactose non-fermenters. Enterohemorrhagic E. coli EHEC. EHEC is prevalent mainly in the industrialized countries in contrast to other diarrheagenic E. coli which are common in developing regions. Serotype associated with EHEC O157H7 is the most common serotype. However, the other strains may account for up to more than 50% of EHEC infections, among which O104H4 strain of EAEC is important. EHEC is usually transmitted by contaminated food, that is, consumption of lettuce, spinach, sprouts, undercooked ground beef. The recent outbreak of EHEC in 2020 was reported in the United States was due to consumption of clover sprouts contaminated with E. coli O103. Low infected dose of EHEC is very low. Only few organisms, less than 10 to the power 2 bacilli are required to initiate the infection. Pathogenesis, EHEC secretes a toxin called virocytotoxin or Shiga toxin. Therefore, EHEC is also called Shiga toxin producing E. coli STEC. It resembles with Shiga toxin produced by Shigella dysentery type 1. It acts by inhibiting the protein synthesis by inhibiting 60S ribosome. It is of two types, STX1 and STX2. Manifestation. The Shiga toxin has the predilection for endothelial cells causing capillary microangiopathy, which leads to HC, hemorrhagic colitis. It manifests as gross bloody diarrhea, abdominal pain and fecal leukocytosis but no fever. Hemorrhagic uremic syndrome HUS, it is characterized by injury to small vessels of the kidney and brain which can lead to bloody diarrhea, thrombocytopenia, renal failure and encephalopathy but without fever. It is more common in children. HUS has 10% mortality and up to 50% of the cases may retain some degree of permanent renal or CNS damage. Diagnosis. Special culture media such as sorbitol, McConkey agar does not ferment sorbitol and rainbow agar are used for EHEC. Toxin detection, demonstration of the cytotoxicity in vivo cell lines, gold standard method. Fecal toxin detection by ELISA or rapid test. DNA PCR probe detects gene encoding for STX1 and STX2 in feces. Enteroaggregative E. coli, EAEC. It's so named because it adheres to HEP2 cells in a distinct pattern, layering of the bacteria aggregated in a stacked brick fashion. Most strains are O untypeable but H typeable. Pathogenesis. Intestinal colonization is mediated by aggregative adhesion fimbri1 regulated by AGGR gene. It also produces EAST1 toxin, enteroaggregative heat stable enterotoxin 1. Manifestation, persistent and acute diarrhea are commonly seen, especially in developing countries. It can also cause traveler's diarrhea and persistent diarrhea in infants. Diagnosis is made by detection of AGGR and AAT capital A gene by PCR and HEP2 adherence test gold standard. E. coli O104H4, its enteroaggregative strain that has caused major outbreaks in Germany in 2011. One peculiar feature of this strain is produces Shiga toxin and can cause HUS. Now, the diffusely adherent E. coli DAEC. DAEC is characterized by ability to adhere to HEP2 cells in a diffuse pattern, expresses diffuse adherence fimbri which contribute to pathogenesis. DAEC is capable of causing diarrheal disease primarily in children aged 2 to 6 years. Treatment. The mainstay of treatment is fluid replacement. The use of antimicrobial should be avoided. The following are the situations where the antibiotics may be considered. Traveler's diarrhea, ETEC or EAEC. For several traveler's diarrhea, azithromycin is indicated. Rifaximin, an oral non-absorbable antibiotic, can also be given. EIEC, although the infection is self-limited, antibiotics such as azithromycin is indicated as it fastens the recovery, particularly in severe cases. EHEC and E. coli O104H4. Antibiotics such as cotrimoxazole, beta-lactams, metronidazole should be avoided as they precipitate HUS. If treatment has to be started, example if positive blood culture, azithromycin is preferable option. EAEC only in immunocompromised patient, ciprofloxacin for 3 to 7 days is recommended. Okay, so this completes our E. coli infections. Next we'll continue in the next video. Thanks for watching. Like, share, subscribe.